Welcome to the deep dive. Today we're diving into something really crucial for gut health, the latest on removing colorectal polyps.
That's right. We're looking at the brand new 2024 guidelines from the European Society of Gastrointestinal Endoscopy, ESGE.
Yeah, and our mission really is to give you the inside scoop on what experts say is the best way to handle these polyps now. Because as we know, this is a huge part of preventing colorectal cancer.
Exactly. We'll cut through some of the jargon. There are quite a few different techniques out there.
Hmm.
And this update really helps clarify which tool for which job, essentially.
Makes sense. Knowing this stuff is important. Effective removal directly impacts, well, cancer risk and survival rates. It's significant.
Hugely significant.
Okay, so let's start small. Diminutive polyps 5 millimeters or less. What's the absolute go-to according to ESGE?
Right. For those tiny ones, the guideline is very strong. Cold snare polypectomy, CSP.
Cold snare, like a little
Yes.
wire loop.
Exactly. A small loop snags the polyp, and importantly, they recommend taking a tiny bit of normal tissue around it, maybe 1 or 2 millimeters.
Ah, safety margin.
Precisely, to ensure complete removal. The evidence backing this up is high quality, so it's a strong recommendation.
Okay, cold snare. Now, what about using cold biopsy forceps? Sometimes you hear about that for tiny polyps.
Yeah, you do. But ESGE actually recommends against using cold forceps for these.
Oh, really? Why is that?
Well, the evidence, though maybe moderate quality, points to a higher chance of leaving some polyp behind. Incomplete resection.
I see. So even if it's tiny, you want it all out.
Definitely. And CSP seems to be the better bet for getting it all.
Got it. Okay, moving up slightly in size. What about small polyps, say 6 to 9 millimeters? Still cold snare?
Yep, still cold snare. The strong recommendation holds for this group too, again with that 1 to 2 millimeter margin.
Interesting. So consistency there.
It really reinforces CSP for these smaller lesions backed by, high quality evidence again.
Okay, so small stuff, sorted cold snare. Now let's tackle the next size up. 10 to 19 millimeters. And these are the non-pedunculated ones, the flatter ones, right?
It's right, flat, no stalk. For these, the recommendation shifts. It's a strong recommendation for hot snare polypectomy, or HSP.
Hot snare. So adding heat into the mix.
Correct. The snare uses electrical current to cut and cauterize simultaneously. It's generally seen as more effective for completely removing these slightly larger, flatter polyps.
Okay, hot snare. Now, I saw something about injecting fluid underneath first. A submucosal injection.
Yes, that's mentioned. It's a suggestion, maybe a weaker one based on lower quality evidence, but the idea is to lift the polyp.
Lift it. How does that help?
It creates a kind of fluid cushion between the polyp and the deeper layers of the colon wall. The aim is to reduce the risk of the heat, the thermal energy, injuring those deeper layers.
Okay. A protective buffer, sort of. Makes sense. Is cold snare ever an option for these 10, 19 millimeter ones, maybe removing them piece by piece?
There is a mention of that, yes. A weak recommendation for considering piecemeal cold snare EMR, that's endoscopic mucosal resection, using a cold snare in pieces.
But only in specific cases.
Exactly. It might be for carefully selected flat adenomas, the ones that look granular and uniform, especially if they're in the right side of the colon, or maybe if the patient has other health issues making heat riskier. But again, lower quality evidence there.
So generally, hot snare, but maybe cold piecemeal in niche situations.
Right. Now, the really big ones, 20 millimeters or larger, large non-pedunculated polyps, or LNPCPs. EMR is the main technique here.
Absolutely. For these large flat lesions, the strong recommendation is conventional EMR. That usually involves diathermy, so heat.
Okay. And that involves the injection lift again.
Yes. Inject fluid to lift it, create that cushion, and then use a hot snare to remove it. Often, because they're large, it has to be done in multiple pieces piecemeal.
Are there alternatives to standard hot EMR for these big ones?
There are a couple suggested, though, with weaker recommendations. One is underwater EMR.
Underwater, how does that work? Instead of air, the colon is filled with water during the procedure. It can sometimes help the polyp float up a bit, making it easier to snare. Moderate quality evidence suggests it's a viable alternative.
Interesting. Any others?
Endoscopic submucosal dissection, or ESD, is another alternative mentioned.
ESD. That's more complex, isn't it?
It is. It's a technique that allows removal in one single piece, en bloc, which is ideal, but it's technically demanding, takes longer, and carries different risks. So it's a weak recommendation, really reserved for specific cases and centers with significant expertise.
Right. Now, you mentioned removing these large ones piecemeal with EMR. There is a crucial follow-up step mentioned for the edges, right, to prevent recurrence.
Yes, absolutely critical. After piecemeal EMR, ESGE strongly recommends treating the resection margin, the edge where the polyp was cut,
How?
using thermal ablation, specifically with something called snare tip soft coagulation, or STSC. Basically, using the tip of the snare to apply gentle heat to zap any tiny residual bits.
Like cleaning up the edges.
Exactly. And the evidence for this is high quality. It significantly reduces the chance of the polyp growing back.
That's a really important practical point. What about using clips afterwards, especially in the right colon?
Good point. Yes, for EMRs in the right side of the colon, there's a strong recommendation backed by high-quality evidence to prophylactically close the defect with endoscopic clips.
Why specifically the right colon?
The risk of delayed bleeding seems to be higher after removing large polyps in the right colon. The wall is thinner there, different blood supply maybe, so clipping helps prevent that complication.
Okay, that makes sense. Let's shift focus slightly. What about sessile serrated lesions, SSLs? They're a different kind of polyp. How are they handled?
Right, SSLs have a different biology. The approach depends on whether dysplasia, those precancerous changes, is suspected.
Okay, so first, SSLs without suspected dysplasia.
For those, regardless of size, the strong recommendation is actually cold removal, either piecemeal, cold snare polypectomy, or cold EMR. Moderate quality evidence supports this. Avoid heat if there's no dysplasia.
Cold removal. And any specific tips for larger SSLs without dysplasia?
Yes, if they're 10 or 15 millimeters or bigger, there's a suggestion, not a strong recommendation, to consider a submucosal injection before the cold snare removal.
Why inject if you're using cold?
It's not for thermal protection here, it's more to lift the lesion and clearly define the edges, making sure you get the whole thing, especially since SSL margins can sometimes be indistinct.
For better visualization of the complete resection. Got it. And what if dysplasia is suspected in an SSL?
Then the approach changes. It becomes a weak recommendation for hot snare polypectomy. The goal here is ideally to remove the dysplastic part en bloc in one piece, if possible.
Because of the higher risk associated with dysplasia.
Exactly. The presence of dysplasia bumps up the concern, so potentially more thorough, heat-based removal of that component is considered.
Okay. Now, what if the endoscopist suspects something more serious during the procedure, like a superficial invasive carcinoma within the polyp?
Big red flag. If there's suspicion of early cancer, the strong recommendation is for en bloc resection. Get it out in one piece.
How? What techniques?
That could be en bloc EMR, if feasible, or ESD, or even more advanced techniques like endoscopic intermuscular dissection or full-thickness resection in some centers. Or, if it can't be safely removed endoscopically en bloc, then referral for surgery is needed. Moderate evidence supports this one-piece approach for accurate staging and treatment.
Makes sense for cancer.
Yeah.
Let's talk about judging these polyps visually optical diagnosis. That seems really key in deciding strategy.
Absolutely fundamental. ESGE strongly recommends performing and reporting an optical diagnosis for every polyp. This isn't just finding it, it's carefully assessing it.
What are they looking for?
Things like the surface pattern, the pits, the blood vessel patterns, using magnification or special light like NBI, plus the overall shape, size, and location. Putting all that together helps predict the risk of submucosal invasion, how deep it might have gone. Moderate evidence supports how crucial this step is.
So detailed observation is key. And the guidelines specify how to describe these polyps in the report, too.
Yes, standardization is important. They recommend describing the location precisely, size in millimeters, and morphology using the Paris classification.
Paris classification.
It's a standard way to describe the shape, pedunculated, sessile, flat, depressed. And for larger non-polypoid lesions, those 10 millimeters or bigger, they recommend classifying the surface pattern, too.
Like granular or non-granular?
Exactly. Granular homogeneous, granular nodular mixed, non-granular elevated, or non-granular pseudo-depressed. These different appearances can hint at the underlying nature of the polyp.
And you mentioned JNET classification, too.
Yes, the JNET classification focuses more on the vessel and surface patterns seen with advanced imaging, helping to predict the histology, like whether it's a low-grade adenoma, high-grade, or potentially invasive cancer. These systems provide a common language.
Okay. Now, sometimes things don't go as planned. What if the endoscopist tries that injection technique, but the polyp doesn't lift, the non-lifting sign?
Right, the non-lifting sign. It can be concerning, but the guideline emphasizes it doesn't always equal cancer.
What else could cause it?
It could be fibrosis, like scar tissue, maybe from previous biopsies or inflammation.
But it could mean deeper invasion.
It could. So if a polyp doesn't lift, but it otherwise looks suitable for endoscopic removal and doesn't have obvious signs of deep invasion, the strong recommendation is referral to an expert endoscopist or center.
Get an expert opinion for those tricky ones. Are there specific techniques for tackling just the non-lifting part of a larger polyp?
Yes, if it's just a section within a larger polyp that won't lift, there are adjunctive techniques. ESGE strongly recommends considering things like hot or cold avulsions, sometimes called casti, to try and remove that stubborn area.
Okay. Thinking about after the procedure now. Recurrence. How likely is it? And what should be done if a polyp comes back?
The guidelines note that larger initial size and piecemeal resection are definite risk factors for recurrence. If, during a follow-up surveillance colonoscopy, there's suspected residual or recurrent adenoma, the strong recommendation is to resect it right then and there using a snare. Don't just watch it.
Get rid of it again. And confirming the cure is important too, not just a quick look.
Exactly. You can't always rely on just standard white light. ESGE strongly recommends confirming endoscopic cure at surveillance using advanced imaging techniques like high-definition scopes, chromoendoscopy, or MBI to really scrutinize the scar and make sure nothing subtle is missed.
Good point. Let's touch on complications. Bleeding. Can you clarify the difference between bleeding during and after the procedure?
Sure. Intraprocedural bleeding, or ITB, happens during the removal. If it needs treatment, the suggestion is endoscopic coagulation like STSC or forceps coagulation or mechanical therapy like clips, sometimes with a bit of dilute adrenaline injected.
Okay. And post-procedural bleeding, PPB, that happens later.
Right, PPB happens after the patient has left the endoscopy suite, maybe hours or days later. If the patient is stable and not actively bleeding heavily, the first step is often conservative management. Just watch carefully.
But if they need intervention?
Then colonoscopy is the first-line investigation. And if active bleeding is found, the strong recommendation is, again, forceps coagulation or mechanical therapy, maybe with adrenaline.
And we already mentioned prophylactic clipping in the right colon after EMR helps prevent this PPB, right?
Correct. That's a key preventative measure based on strong evidence.
Okay. What about antibiotics? Are they needed routinely when removing polyps?
Generally, no. ESGE does not suggest routine antibiotics for conventional polypectomy or EMR in the colon. The risk of infection is very low.
Any exceptions?
There's a weak suggestion to consider prophylactic antibiotics for EMR, specifically in the distal rectum near the anus or at the anorectal junction. The bacterial environment and drainage are different there, so maybe a slightly higher theoretical risk.
Got it. Once the polyp is out, handling the specimen correctly for the pathologist is vital, isn't it?
Absolutely crucial for an accurate diagnosis. Each polyp should go into its own labeled container with 10% buffered formalin preservative.
And for the big ones?
For large lesions, 20 millimeters or more, they recommend pinning the specimen flat onto cork or foam board.
Why pin it?
It prevents it from curling up and helps the pathologist assess the margins and the overall structure properly. For pedunculated polyps, sometimes a needle through the stalk helps orient it.
And communication helps too.
Definitely. The endoscopist telling the pathologist about the removal technique, any difficulties, relevant patient history, that collaboration is favored.
We talked about expert referral for non-lifting signs. Are there other cases that should definitely go to experienced endoscopists?
Yes, the guidelines are strong on this. Large polyps, sessile ones, laterally spreading types, or anything complex really should be removed by trained, experienced endoscopists in centers with the right resources.
And importantly,
Polyps that don't show signs of deep invasion shouldn't just be sent for surgery without getting an opinion from an expert endoscopy center first. Endoscopic removal might still be possible and safer.
that's a really key point for avoiding unnecessary surgery. One last practical thing. Tattooing. Injecting ink near the polyp site. When is that recommended?
Tattooing is strongly recommended for a few reasons. If the lesion might need surgery later and needs locating, if cancer is suspected in the removed polyp to mark the site for surveillance or surgery, or if the scar might be hard to find later, like after a large EMR.
Where should the tattoo go?
Usually about 3 to 5 centimeters distal to the lesion further down the colon, and generally one tattoo spot is sufficient.
Well, this has been an incredibly detailed look at these 2024 ESGE guidelines. I think the main takeaway for you listening is just how tailored polyp removal has become.
It really has. It's not one size fits all. It's about careful assessment size, shape, location, surface patterns, and then applying the right technique, whether it's cold snare, hot snare, EMR, maybe even ESD in expert hands.
And all these refinements, treating the margins, using clips preventatively, are aimed at making the procedure safer and more effective in preventing colorectal cancer.
Precisely. It equips endoscopists with a clear, evidence-based roadmap.
So here's a final thought to leave you with. As these endoscopic tools and our understanding of polybiology continue to evolve at such a rapid pace, what do you think the next big leap will be? What future advancements might further refine how we detect and remove these lesions, pushing those cancer prevention rates even higher?
That's the exciting question, isn't it? AI-assisted detection and characterization is certainly growing fast, maybe even more minimally invasive resection techniques. It's a space to watch.
Definitely something to ponder. Thanks for tuning in to the Deep Dive.